there are a couple of questions that we've received more than once throughout the year. As I'm getting questions and responding to questions, I always reference our guidelines for care first, and will, if it is a treatment or a question that is related to the guidelines, I will tell the person that I'm talking to where I found the answer so that we can, find it again later. I will consult with our state staff if there's something that I don't know, or with our Sweet Success clinic experts. We do multiple different sources of information so that we're conveying as complete information and as accurate as possible. And I'm finding that we're still having a lot of questions regarding billing and payment for services, and this really hasn't changed. It's not based on how the diagnosis is made. It's based on the services you're providing, the CPT codes, and the ICD-9 codes that are being used. So what we suggest is that you get together with your billing department and come up with a consistent list of CPT codes and ICD-9 codes that you are using that have been approved and that have already been through the system. The other thing, too, to remember is that those ICD-9 codes are changing. In October, everybody's supposed to be switching over to ICD-10 codes. I have been online and did a couple of searches, and there are multiple websites that will help you convert from ICD-9 to ICD-10 codes. I didn't pull any out, but if you do a Google search for ICD-10, you'll get multiple hits and multiple sites that you can go on. I do suggest, however, that you check who they are and make sure that they're reputable and that they're giving you accurate information. The other thing that we do have is on our website, under affiliates and forms, there is a summary of Sweet Success services. There's a description and a visit length, and it gives you some CPT codes that meet those definitions that you can use. Before I move on to interesting articles, one of the other questions that I have been getting is about staffing and what changes in staffing mean for your affiliation status. If you lose a staff member, it doesn't mean that you are no longer an affiliate. What we do ask is that, for example, if you don't have a dietitian or a nurse educator, that you have a place to refer them. If you have lost your social worker, that you find a social worker that you can refer to if the need arises. As long as you are still following the guidelines for care and providing care according to those guidelines, and you have trained staff and you have a referral source, you are still an active affiliate. Okay, so interesting articles. So I've actually found one article and two abstracts that I wanted to bring up and share with everybody. The first one is the independent effects of maternal obesity and gestational diabetes on pregnancy outcomes. This was published in Biomed Central Endocrine Disorders. This is a peer-reviewed article, and the publisher is open source. So this article was published in June of 2014. It's online, and because it is an open source, I'll be able to put a link on our website to this. So what they're doing is looking at singleton pregnancies. They're looking at the independent effects of GDM and obesity on pregnancy outcomes. It's a retrospective study. They looked at 2,700 postpartum women in Saudi Arabia. So they were looking at pregnancies that went through at least 37 weeks gestation at time of delivery and that had a documented record of maternal weight and height. They stratified the cohort into based on BMI and GDM screening. So there was 4 groups that they were looking at. One group that they were looking at obesity over was a BMI over 30, and the GDM was defined, as you can see on here, as a 3-hour 100-gram OGTT. They used the Carpenter and Kustan criteria. So the 4 groups was, group 1 was no obesity, no GDM. The next group was no obesity with GDM. The third group was obesity, no GDM, and then the last group was obesity and GDM. So what they concluded was that maternal obesity and gestational diabetes were independently associated with adverse pregnancy outcomes. The combination of both of these conditions further increased that risk. There is a significant increased percentage of C-sections, macrosomia, preeclampsia, birth weight, and length of newborn. And statistically significant was p-value of less than 0.001. And one of the examples that they had in here was preeclampsia. They saw preeclampsia in 0.5, so less than 1% of the group with no obesity and no GDM, 1.9% GDM, no obesity, 1.5% obesity, no GDM, and 3.5% obesity and GDM. So that's quite a significant increase. The article can be found, or the abstract can be found at the link that's on your handouts, and like I said, this is open source, so I will be able to put a link to the article itself on our website. And then the 2 abstracts that I found interesting, one is related to the birth weights and how that is associated with it, increased risk of type 2 diabetes and obesity, and then the other one is looking at hemoglobin A1Cs in early pregnancy and how that predicts gestational diabetes. Now, I was only able to look at the abstracts for these. The first one, I don't have access to that journal, and the second one isn't published yet. The only thing that's on the website is the abstract. So the first one, the birth weight and risk of type 2 diabetes and obesity, is looking at the Swedish National Register, looked at 759,999 singleton births, followed them to age 27 and a half through 37 and a half, and it was looking at the long-term effects. What they found was that high birth weights increase the risk for type 2 diabetes in young adult males, and increase the risk of obesity in both males and females. So, for example, with birth weight between 2 and 3 standard deviation scores, males had a 1.9 increased risk of type 2 diabetes, and if the standard deviation was at 3, that risk went up to 5.4. The next abstract that I thought was interesting, and I would like to see what the final article looks like, is they were looking at hemoglobin A1C and seeing if that would be a predictor for gestational diabetes. It is a retrospective study. They looked at 526 singleton births over a 2-year period, and they had to have had an early screen with a hemoglobin A1C at less than 20 weeks gestation. So they were tracking those people who had a hemoglobin A1C between 5.7 and 6.4%, and they were comparing those to people who had an A1C below 5.7. So what they found was that 1/3, or 27.3%, of those who had an A1C between 5.7 and 6.4 went on to develop GDM. The percentage for the less than 5.7 group was only 8.7. And this increase, the threefold increase, remained even after they adjusted for age and BMI and gestational age at the point where A1C was collected and ethnicity. So both of these abstracts I thought would be good for some follow-up on. The last thing that I would like to talk about before we move on to questions is change in our scope of work for the Resource Center. We've mentioned during our last update, and we've been sending everybody emails to remind them that as of July 1st, the Resource Center will no longer be producing and distributing hard copies of any of our educational material. It's all going to be available for download on our website, and it's on the resources page. Right now, nothing other than the organization has changed. We haven't posted anything. That won't be done until the end of the fiscal year. The two areas where you can go or used to be able to go to purchase material, the links are still there, but you won't be able to go anywhere because we cannot take any additional material orders. So one of the last things that I would like to do at this point is take a minute to thank everybody that we have been working with throughout the years. It's been a real pleasure to get to know everybody and to work with everybody. I think I've met a lot of our affiliate staff at different events, especially with Success Express. We have worked on material testing and development, and this has been a really interesting and fun contract to work with. Unfortunately, CDPH did not renew our contract to manage the Sweet Success Resource and Training Center. So as of July 1, 2014, so that's about 2 weeks, the management of this program is going to move to another organization. If you need more information on those details and contact, please contact the State Maternal, Child, and Adolescent Health. They'll be able to tell you who to contact, who to talk to, and when. So our last day with the program is going to be June 30th. If you have any questions, if you have any issues that we here in San Diego need to do something about, please contact us as soon as possible. Again, after June 30th, you can contact the State Maternal, Child, and Adolescent Health, and that is their contact information is on this page as well as mine. And again, on behalf of all of our staff here in San Diego, I want to thank all of you for your support, for your hard work on behalf of all of our patients, and wish you all continued luck and progress with dealing with your patients and taking